Hey everybody, Dia Davidson here with another conversation on race. This time we're talking about mental health in the Black and Brown communities. Joining me now is clinical social worker Wilma Peeples. She is an expert with more than 40 years in the subject. Wilma, it's good to see you.
Well,
Let's
thank you
talk,
so much.
let's
Thank you
talk a
so
little
much
bit.
for the invite.
Yes, indeed. Let's talk a little bit about mental health, especially in this pandemic. It's affecting people in a variety of different ways, regardless of what community. What are some of the things that you're seeing and feeling and thinking about preserving and protecting everyone's mental health?
What we're seeing, or what I'm seeing in my practice, of course, is related to the standard symptoms that most people have, and that is anxiety and depression, and the stress of dealing with the changes within the environment of people's homes, jobs, has contributed to even more so of these symptoms coming forward.
Are you finding people are seeking help? Are they able to do it through things like this, like Zoom, or are you finding that people are becoming even more reclusive, if you will, and more introspective or introverted with their issues?
Well, first of all, folks are not having an opportunity to work in their particular organization, and being at home where the organization provided a great deal of support, um, common communication with other people. And so the mental health, at this point, we're delivering more telehealth. And fortunately, if individuals had the insurance coverage, then their care could be provided through their telehealth services. The insurances are now paying for telehealth. They didn't used to pay for telehealth. So now they have agreed to deliver mental health services through telehealth. And so the part here also is that individuals need to know what their healthcare benefits do provide. But of course, you have a loss of jobs and a loss of benefits. So if individuals are still having some type of work, from home, or they're working in areas where they're able to continue their jobs, many factories are still open and providing employment. So therefore, they have more access to their mental health care benefits.
What are some of the warning signs that we might need to do more than just get up from our workstation at home and get a breath of fresh air? What are some of the warning signs that people need to kind of not create a checklist, but kind of be aware of, that maybe not just adults, but even children are being impacted, that we need to seek out sort of a third set of eyes?
Well, people can be more irritable, not sleeping well, sleeping either too much or not enough, not able to fall asleep fairly quickly. Within about 15 minutes, one should be able to fall asleep and not wake up in the middle of the night, and have disruptive sleep. People can have disturbing dreams that they're not aware, that they've become aware of. It's not getting fully rested if their dreams are disturbing. Eating too much or not eating enough. Lack of activity, not wanting to go outside, not wanting to walk or be physically active. They can have neglect of their environment, meaning things can be too cluttered around them. They can start having thoughts of more negative thinking, thinking that is about the world situation, hopelessness, helplessness, feeling like nothing is going to change. They can be nervous, just have general nervousness inside that they can't connect with.
And
Why
we're
that
noticing a lot of people are watching, maybe overwatching news and political coverage and things of this nature. Do you think that we need to pull away from screens a little
Well,
bit?
sure. I mean, that's what generates a lot of the helplessness and hopelessness. They don't see a end in sight. The unemployment rate, and so it not knowing what's going to happen, or they're lose. What am I going to lose? What am I going to have to give up? That people are having to move in with each other. So more people are in the home, and that stress can create brain chemistry imbalance, that amount of stress. And
What about
if they're already carrying some elements of depression and anxiety, then that can elevate that depression and anxiety.
scenes of the social protest movements that are going on? We see point and counterpoint, and we're seeing militias, and we're seeing all of this. Is that also helping to create a sense of nervousness or disconnect?
Absolutely, but I think in the African American community, I think that there's been a thought of finally being recognized that African Americans carry a great deal of burden anyway, trying to deal with the systemic racism within their employment situation, or in their neighborhood, or in the community and the stores that they frequent. And so that's carried by African Americans. And so that lends itself to even more stress. And so having the civil rights issue at this point actually gives African Americans empowerment, that the group is being recognized, that we're hurting, that Black people are hurting, Black people are needing more support, and so it's kind of a catch-22 if you want to look at it that way. But I think for the most part, it's one of empowerment as well.
The church has always been a place where we could have a cathartic release, if you will. Do you still find that that is a place of refuge, if you will, even in the era of COVID-19?
Absolutely. The Christian experience or other religious experiences help people to bridge that gap to where they can go and feel that sense of connectivity and acceptance, that they can do works within the church to give them the feeling that they are, that they're wanted, that they can be productive. And so it is helpful for the activities that the church brings to the African American community.
Let's talk a little bit more about the African American community and mental health. Do you find that as a group, we are embracing of psychologists, psychiatrists, social workers, or is that still something in our community that is taboo? And then on the greater community, are we seeing the same trends?
Well, within the African American community, there's always been the distrust of people delivering healthcare services that don't look like them. So that distrust has always been there for someone diagnosing an illness. It does require people, healthcare professionals, particularly in the mental health field, to be trained in terms of understanding multicultural issues and particularly trained in terms of understanding the African American experience. And so if the healthcare professionals, particularly the mental health professionals, do not carry enough training to understand about the African American experience, then African Americans are not going to want to be a part of that care with that care provider. I don't think that African Americans are oblivious that there are things going on within them, that something's not working properly. But who do I trust? And we don't have enough mental health professionals anyway to cover the number of people who have mental health issues. There are not enough mental health trained people. And then there's not enough mental health trained people who understand how to work with populations that are different than they. And we don't have enough African American mental health professionals across the country, and even in the local community, Central Kentucky area.
Wilma, do you think that with the death of Robin Williams as such a larger than life figure, regardless of race, do you think that his death and his struggles helped to shine a light on this subject that has been in existence since man has been on earth? But do you think that when people are more transparent, especially people that we see in the media, do you think that that's helping? Or do you think it's, we see it, we emote, and then we go right back to our corner?
I think that people who are in the media, actors, actresses, so forth, professional people who talk about their experiences, I think it does help, because mental illness knows no boundaries. There are no boundaries. It affects all races of people, all cultures. It affects all income. It's just that the difference is these individuals with the income are more likely to receive the help from trained, highly trained people. In that case, they get the best of the best trained care. And at times, not all time, not necessarily, because mental illness is a slippery slope. It's, you think you're understanding the different dynamics and the symptoms, and of course the DSM guides us in terms of looking at the criteria to determine the correct diagnosis. Robin Williams' diagnosis had to do, as it came out later, most recently, Lewy bodies, which is a form of dementia. And it can be misdiagnosed. A person with Lewy bodies can be diagnosed with schizophrenia because they are having the symptoms of which would be in that type of diagnosis: auditory and visual hallucinations, paranoia. And so people can be misdiagnosed as schizophrenia, when it really could be a form of dementia such as the Lewy bodies. African Americans tend to be diagnosed with higher levels of more serious mental illness than other populations, meaning therefore the treatment may not be going to be effective if the diagnosis is not made accurately. That's the most important thing. And then when you have other medical problems and medications are delivered to treat diabetes or cancer or other disorders, medications of those disorders can have an effect on the mental health of a person as well.
Well, do you think it's an attempt to put a quick label It's sort of like with young Black males, school-age children. It seems like there was an era where Ritalin, every child, every male child, Black child, was almost given Ritalin as a way to control hyperactivity, when now they're saying that many of them should never have been given that particular medication because it was a lack of sensitivity on the teacher's part. It was maybe a at-home issue that needed to be addressed. Do you think it's just a quick labeling?
Uh, there can be misdiagnosis. There can be that behaviors that are similar to what you would find in ADHD, attention deficit hyperactivity disorder. Also be like anxiety. And it can also be looked at as depression. But if those aren't truly evaluated, then the children can be misdiagnosed. Behavioral problems can be automatically seen, particularly in children, as ADHD. And, we don't look for the slow process of evaluating and treating behaviorally, meaning behavior modification, meaning parent-child education, helping the parents to develop a behavioral plan at home that can be applied also at school. We don't have enough of our mental health providers that get involved in working with the school. Here in Fayette County, they came to the decision to hire more mental health providers, clinical social workers in particular, and certified social workers who will be under the supervision of a clinical social worker. I provide clinical supervision, and I teach the clinical supervision course that these individuals who want to provide clinical social work supervision to non-clinical licensed social workers. And I'm encouraging them. I truly want the mental health focus in the school to look at engaging the delivery of services after hours. We just can't stop treating at 4 o'clock. We need to treat according to the working hours of our parents and children, particularly, to be able to see these individuals, not pull them out of the classroom, that they need to be seen after school hours. Part of that is the stigma of being pulled out of the classroom, and kids don't want that. And so or they may want that because they don't want to be in the classroom, but I really encourage the schools to look at extending mental health services after hours and on weekends, Saturday particularly. If we don't move in that direction, most mental health care is provided, probably about 5 or 6 o'clock, unless there's a private practitioner providing the services. But organizations tend to provide their mental health services, during the day when kids are in school.
Let's talk about Kentucky as far as mental health. Where do we fall on the list? Are we doing a good job? Are we seeing more incidences of it? What seems to be the main issue diagnosed? Where are we as a state?
It depends upon the age of the person who's seeking or needs to be receiving mental health care. As it depends upon whether or not you're looking at it at the private rate, at the private care level, meaning insurance, your private insurance carriers, or you're looking at it at the public insurance, determines how well we're doing. And whether or not people have insurance will determine how well we're doing.
Well,
so if you look at the number of people who are in need of mental health care, we probably are not providing enough mental health care.
when we look at mental health care, are we looking at also some of the other social issues of drug abuse, alcohol abuse, even domestic violence and cruelty to our children? Are we looking at all of that in that spectrum?
Yes, I mean, mental health care as it relates to substance disorders is combined in with the Diagnostic Statistical Manual, which oversees all mental health diagnoses, and that classification to understand, what is considered depression, what is considered anxiety, what is considered a neurodevelopmental disorder, what is considered a conduct disorder. What are all of the criteria that we look at to determine what diagnosis is made? So if we have a true, strong mental health care system, then all mental health providers have to be also able to provide case management services, being able to work across all areas of where people are experiencing troubles in their life. So that could be in the forensic area or corrections area. That could be in the school setting. It's all institutional situations that we have to be able to provide mental health care in. So as a clinician in private practice, you have to be able to do case management, meaning you have to be able to refer cases coming into your practice from the social service agencies, from the court system, from all across the spectrum. But I find that there are times when we don't want to do that. Clinicians have to be trained to be able to understand all of these different institutions of what they're experiencing and what their clientele is experiencing. We have to keep that knowledge base going. What's changing? What's new? What's working? What's not working? In particular, the school system. We have to be involved in the school system as mental health providers. We have to know what the social workers and the guidance counselors and the teachers are experiencing in the classroom, as well as the home. We have to be able to do intergenerational counseling. We have to have the family as a whole sometimes in the counseling session. And we have to be aware of the dynamics of domestic violence, what's going on in the home, and how to manage those situations with our clients. We have to be able to work with people who are perpetrators as well as the victim.
So if someone is thinking and listening to this and saying, well, maybe I need to just come and talk, how should they go about selecting? Should they just go through, we don't have phone books really anymore, but should they let their fingers do the walking? Should they reach out by a website? Or how do you suggest people find that right fit, that right person, that right experience level that they'll get the biggest support or the biggest help from?
One of the things that has been helpful with the insurances is that they have vetted every licensed professional mental health person. They have checks and balances in there that we have to be licensed, that we have to have certain educational level, that we have to have certain continuing education to work with certain issues and problems that people may communicate when they're calling their insurance company. The insurance companies will provide a provider list to individuals, and then they go through that list and make the phone calls and have the conversation with the office of that provider to determine if they are available, to determine if they work with this particular problem. I recently had a call from an insurance carrier that says, are you able to provide this, this, and this? Are you available? So they do checks and balances with clinical providers to see if they're available and are they available to work with this particular individual. And that's been helpful for people. And then they link individuals up on the phone with the provider's office, particularly if it's a clinician that is available to take the call. Does that make sense?
Mm-hmm.
Where the potential client is listening in as the case manager for the insurance carriers. We also have many employers and insurance plans have employee assistance programs. And the employee assistance program that many employers have and plans have attached to it is that individuals can have so many visits that are no charge to them. So that's what we call no co-pays. Employee assistance plans can be anywhere from 3 sessions to 8 sessions.
Oh, wow.
Are available. I think Toyota probably has the largest number of sessions available that's free. They are up to 8. There's no, you talk with a caseworker through who initiates the referral to the clinicians. Medicaid, the Affordable Care Plans have a similar type thing where they give the member a list of providers, and also all of this is online with the insurance. The group that is missing probably in terms of how do I get connected would be the group that has no insurance. Okay. And of course, if they have a landline, then of course you're going to have the telephone book to go through the landline, which is listed in the yellow pages of all clinicians. Of course, you have the internet that they can go to type in mental health providers. With this telehealth, it's really making it very much available. And for people to seek care by using some of the telehealth available services that are listed on the internet. The problem is, how do people pay for it? That group that falls in and that's a big group now, how are they going to pay for it? And sliding scale is not available for people across the board, meaning that clinicians may not offer a sliding scale fee, just like hospitals don't offer necessarily a sliding scale fee. But if someone is willing to provide the service without charge to the person, knowing that they don't have insurance and they don't have the ability to pay, it's hard to find those providers that are willing to do that to some extent. And so we do have difficulties in making the services available to those who do not have the ability to pay.
Senior citizens, do you find that they seek your help or seek help? Because many of them would have Medicare, and I'm guessing that would be a part of their benefit.
Yes, the provider will have to be an approved provider under the Medicare program, just like a hospital or a doctor's office. And so you do have some clinicians that will accept Medicare, and you have some that will not accept Medicare. But yes, seniors do have an opportunity to have Medicare to reimburse that care at the same percentage rate that they would, they have a certain set contract rate that you have to follow. And then individuals may have a Medigap insurance, and that will pick up a portion of that 20% that Medicare doesn't pick up. and but not all clinicians accept all of the insurances that are available to people that are able to write in the state of Kentucky. One of the problems that we have, of course, in different jurisdictions of licensing law that license professionals is that you can't go across state boundaries. You can't go across the state line to provide services telehealth. It's complicated the way the law is written. Right now, due to COVID, if the person was seen in your jurisdiction or in your state, then you can continue to see that person out if they've moved to another state. But it's a little more complicated for receiving care across state line.
Wow. Fascinating. Fascinating. And I guess this is a conversation that people need to have with family, need to have with someone who's close to them, because mental health is important. It's an inventory that all of us probably from time to time need to make sure that everything is kind of lining up as best we can. And so it could be something from the cradle to the grave that needs to be a lifelong journey.
It's always, because developmental phases. We never totally self-actualize. And there's certain mental illnesses that a person has to accept that if they have that diagnosis, that medications may have to be a part of this. It's not just the therapy. And in fact, people who have are treated with the medication route, psychotropics, that with therapy, the combination of the two is a much better outcome and than just treating medication only or just treating therapy only. If a person needs medications, they need medications because there is a brain chemistry balance issue here that has to be in place. So the American Psychiatric Association in the Diagnostic Statistical Manual says that much to do with physical is mental, and much to do with mental is physical. It's a biopsychosocial approach that we have to have, an integrated approach. There's integrated medicine. There has to be integration medicine that includes mental health as well. That we cannot be our own little island mental health providers. We have to be a part of the medical side too. Fortunately, we do have our hospitals, particularly, that are physician practices that have a clinical person in the office. Usually it's a psychologist or a clinical social worker who is actually working with individuals in the physician's offices, primary care offices.
To take care of the total person.
To take care of the total person. Yes.
Wilma, thank you so very much for sharing your time and your expertise. And thank you also very much for listening in on this conversation, this very important conversation on mental health here in Kentucky. If you're interested in any of the other conversations, be sure to check out all of LEX18's social media platforms. Until next time, I'm Dia Davidson.